Check, start the countdown.
Okay, sir, please start in 3, 2, 1. Please start soon.
Okay. So, good evening, speakers and everyone joining us today. It is a genuine privilege and honor to welcome you all to the Bayer Eyesight meeting. Today, we are conducting this meeting on DME and AMD. And our first topic is NMD, critical information from clinician to enhance their patient outcomes. And the speaker is Dr. Saptoshi, sir. Sir, if I say about the sir education and training, Sarah has done fellowship from International College of Ophthalmology in the year of 2011, DARC certification for DA and color fundus photography in the 2012, a senior resident VR, UVA and AIMS, New Delhi from 2014. Sir is now associated with Disha Eye Hospital as a consultant VR surgeon. And our second topic is evaluating anti-VEGF drugs, molecular characteristics, and their impact on the treatment success. And the speaker is Dr. Manavjyoti Burman, sir. Sir is highly distinguished ophthalmologist and VR surgeon based in Guwahati with a 28 years of experience. He is well known for his specialized experience in ocular oncology and complex retinal. And the third topic is case-based insights, a prevention in managing DME. And the speaker is Dr. Shomahu Mondal, sir. Sir is the HOD of the Retina Department of Shushudai Foundation Research Center. He has presented papers in several national conferences. He has cleared clinical examination from International Council of Ophthalmology UK. He specializes in different medical and surgical complex via lasers and surgeries. So thank you. And now I hand over the session to Saptoshi sir for his presentation.
Okay, I'm starting my slide share, okay? It's on?
Yeah, it's on.
Okay, thank you for the introduction. I'll be speaking on neovascular AMD and especially the role of Eylea in treating it. So first we need to, can I minimize, wait, yeah. We need to know the burden of AMD in the world population basically. So the crude prevalence is about 2.4%. But if you look at the age group of around 70 to 90, the prevalence is much higher. Over 80 years, it actually becomes 12%. That is about 1 in 8 is actually affected by it. The symptoms can present as just blurring of central vision, but the most distinctive complaint is visual distortion or metamorphopsia. As the disease progresses, there is a central scotoma and then generalized blurring. Symptoms of AMD usually appear suddenly and worsen rapidly. Sometimes the lesion might be there, and when it bleeds or when the scar encroaches the foveal center, that's the time many of the patients do present to us. So this is just a pictorial representation. As you can see, it can cause a profound deterioration in the quality of life of a patient, so needs to be treated early. The stages of ARMD can be divided into early, intermediate, and late. Early is basically will not affect vision. There are only mild RP changes and some deposits. To better clarify it, we can look at the ARED simplified classification. It can be divided into 4, category 1, 2, 3, and 4. 3 is basically intermediate, where we start antioxidants, and category 4 is advanced ARMD, which is wet ARMD and geographic atrophy. Wet ARMD requires intravitreal injections. You can also start antioxidants at a category 2 stage after discussing with the patient, but generally it is recommended at intermediate stage. So this is where the vision problems actually start in neovascular ARMD, which presents very rapidly, while atrophic can be a gradual creepy process. And most of the patients we can't help at the moment, apart from few trials being conducted elsewhere. So how do you diagnose ARMD? It's basically a clinical diagnosis at first with slit lamp biomicroscopy. For patients being treated, we can recommend amstelagrid, or for the other eye, if one patient has been affected in the right eye, probably in the left eye, you can recommend amstelagrid to pick up early. In my practice, actually, I don't do routine fluorescein angiography or ICG, but in cases where you are doubtful, you might go for it, or for documenting a polyp, and if you have access to ICG, you can use ICG dye. Apart from OCT, you can use OCT-A to find out whether it's responding or not if you have doubt with just the OCT. So what's the most important part of ARMD needs to be treated early? Why? Because it's a very fast growing disease. If you look at it, the average growth is about 5 to 10 microns per day, while an aggressive case can also grow at within about 24 microns per day. So what are the factors driving this disease? It's quite, we all know, but I'll still just revise all this. So VEGF-A and platelet-derived growth factors act via VEGF receptors. The VEGF receptors are of two types, VEGF receptor 1 and VEGF receptor 2. So aflibercept or Eylea takes care of both VEGF-A, VEGF-B, platelet growth factor, and also heterodimers of VEGF-A and platelet growth factors. Thus, it prevents excessive activation of VEGF-R1 and R2, which can result in increased vascular leakage and edema and inflammation and pathological neovascularization. So how do this I have added? So basically, what are the receptors? How do they differentiate in the disease process? VEGF-R1 is mainly responsible for the fibrotic progression and persistent deposits under the subretinal space, while VEGF-R2 is more responsible for the fluid leakage, active exudation, and the microvascular branching you see in the OCTA. How do the drugs differ in their actions? If you look at ranibizumab, bevacizumab, and baricitinib, they act only at VEGF-A, and they are modified antibodies basically. They therefore prevent receptor activation. However, they do not inhibit platelet growth factor. VEGF-R1 still remains susceptible to activation via the homodimers and the heterodimers. While aflibercept is a trap, basically it forms a cage around the VEGF. So it can't go and activate either of the receptors. And it also prevents binding by the platelet growth factor. So it has a much higher affinity to VEGF and also takes care of the other pathways as well. So as you can see in this diagram, if you just block VEGF-A, there are still other factors which still remain in the eye. We can still start the disease process. So aflibercept has that advantage. So it does take care of inflammation as well, if you can say, in the disease process. If you look at the affinity, that's where aflibercept strikes the top marks. It binds very tightly and has a good half-life of around 9.1 to 11 days. Brolucizumab takes care by pushing more drug into the eye in a small volume. Faricimab has an advantage, as in it also targets Ang2. But I will focus on aflibercept today, so I'll talk about that. Now I'll be talking about a few randomized control trials and real-world examples. So one of the trials was ALTER. Why we are focusing on ALTER? Because it was a proactive treat and extend regime. While the VIEW-1 was a fixed dosing regime, ALTER was a real-life trial which we could replicate in our clinics probably. So it was a 96-week trial evaluating Eylea using a proactive treat and extend protocol in 246 patients. All patients received 3 initial monthly injections followed by mandatory injection at week 16. At week 16, patients were then split into 1:1, 2 arms. One would be treated and extended at 2-week increments, while the other was at 4 weeks. The core takeaway from this was both arms achieved excellent identical vision gains at 1 year. That was approximately plus 9 letters. 10 letters is approximately 2-line improvement in the Snellen chart. So that's quite good. And it maintained them through week 96. By study end, over 40% successfully maintained a maximum 16-week interval, while 60% probably at 2-week treatment interval, the patients could be maintained. This is a graph which shows the story of the patients. So aflibercept does have demonstrated unsurpassed durability with a proactive TNE regimen, extending up to 60% at even if you treat it at 12 weeks, and 46% at if you treat it every 4 months or 16 weeks. What you can also tell the patients is the number of injections they are getting in the first year. In the second year, it usually drops to half, if you can see it from this trial as well. Another good story from this trial was those patients which could be extended to 16 weeks, up to 96.2% were maintained like that. So if a patient is responding well, is requiring fewer injections, they do well even much later. This is a follow-up study of the VIEW-1 trial, which was basically, first of all, a fixed dose trial. There was an extended phase after that, and post that there was a range trial where the patients were followed up with a proactive TNE. So what this graph shows that even if you're following a patient who has been treated for say 5 or 6 years, the letter improvement still stayed at 7 letters, which is quite good. These are a few retrospective or observational studies from the Fight Retinal Blindness Registry. So I like to stress on the number of injections. Basically, over 2 years, these patients received about 13.6 injections, and the letter gain was about +6 or +7. So moderate gain, not bad. By month 24, but 24% of the eyes which were being treated were beyond 12 weeks and beyond. So that is also a good story from this trial. Even the study for Moorfield, it is a much longer trial. We have data till 4 years. So over 2 years, the patients were receiving about 12.3 injections, and at 4 years, the mean injections were about 19.3. The vision gain at year 2 was +7.7, almost 8 letters. That is quite good. And by year 4, it was around 6.3. So quite good results. Similar trial by Jaggi et al. In Switzerland, the average injections at 2 years were 13.2 and at 4 years around 24. So they probably used, they might have been a bit more strict while they are treating their patients. The gain at 2 years was quite good, +9.8, and it's even reflected in the data. And year 4, it was around +6.3. So it's quite similar actually. So we see on the left the outcomes of aflibercept RCTs, while on the right we see the real world examples, or like how you and I will practice in our OPDs. The results can be replicated with a slightly proactive way by checking out the OCT, hemorrhages, vision drop. So fixed dosing might be good in the first 6 months maybe. After that, TNE works every 12 weeks or in some patients 16 weeks as well. Now I'll be speaking about PCV, which is a cohort of CNVM as such, but it's a different kind of a game. It's much more common in our Indian population as well as Asians. We underestimate it. I probably feel 40% of the patients are PCVs in the long run. So one of the key trials done in this was PLANET. PLANET was a prospective multi-center double mask trial. The patients received 3 initial monthly doses, and then they were randomized into 1:1 group. At week 12, they were kept fixed at every 8-week therapy till week 52, unless some rescue criteria was met. What is rescue? When the patient, you feel the treatment is suboptimal. You are finding fluid, the vision is dropping, you are seeing new hemorrhages. Those patients were given an option of sham PDT or active PDT. But surprisingly, only on an average, 15% of the patients actually needed any active PDT. So week 52 was the primary endpoint. And beyond that, it was TNE, treat and extend, till week 96. So if you look at the graph, the letter gain with monotherapy was around 10.8, and with some patients requiring PDT, it was 10.7, and that was maintained till week 96. So the results in PCV are also quite good. If you look at polyp inactivity of the polyps, in both treatment arms, around 80% of the patients showed no evidence of active polyps. Active polyps, basically, it's not saying that everything has regressed, but they are not active on ICG, or there were no SRF on the OCT. Across clinical trials and clinical practice, aflibercept monotherapy achieves clinical meaningful results in all patients of PCV. So these are various trials which have been stated, and there are few case series done by various groups. So the letter gain is quite good. Now, if you look at complete polyp regression, which is defined by ICG, basically, you can see an average regression of approximately 38 to 44% in the PLANET trial. 44 was with active PDT and 38 was with sham PDT. So basically, even with monotherapy, probably you'll be regressing around 38 to 40% of your polyps, which is quite good, I feel. Before, in our ranibizumab era, it was not that great. Now coming to the main factor which differentiate aflibercept from most other drugs. It's the safest drug probably, in my opinion. Even the market data shows that. If you look at 10,000 patients, the incidence of retinal vasculitis is just 0.006, while of occlusive retinal vasculitis is 0.002. If you look at brolucizumab, it's 5.6 and 3.0. The problem is not about the incidence, it's about the surprise factor. You're treating a patient, you don't know who is going to get hit by the car. So I love Peganax also. I'll not say it's not a good drug, it's a great drug. It sometimes punches way above many drugs, but this risk factor needs to be considered in your one-eyed patients. And if you are counseling your patient, you should mention about IOI rates to the patients. Faricimab fares somewhere in between the two drugs. It's still a new drug if you call it like 3 or 4 years, like in clinical practice. Like for me, I've been using for 3 or 4 years now. I'm getting good results with faricimab as well. The incidence of vasculitis is lesser than brolucizumab, definitely. But if you look at if you can use the word, say, a legacy drug, aflibercept is that. It's a safe drug. So you are looking at about 12 weeks of action for aflibercept, and for the other drug, say faricimab, you are looking at 16 weeks. So you have to choose your patients according to both the safety and the longevity. Hence, if you look at the data, the number of patients that Eylea has gone through or aflibercept has been given is very huge data. And main is the rate of endophthalmitis and IOI is much lower than other drugs. I'll just brush through this because I think I'm running out of time now. Like, this is a patient, this is a doctor patient actually. I've been treating for the last 3 years. He was on Accentrix for a long time. Before that, he was treated elsewhere on Accentrix, or it was branded Lucentis. So he has been on treatment from 2013 till 2026 now almost. So, and just scanning through the scan how PCV behaves, like just scanning. The worst vision this doctor had was 624 at once, and the best vision right now is 6/9, 6/12. But still, even despite being treated by so many drugs over 13 years, we still need to keep treating. But I like to mention this patient is being treated every 3 months with Eylea, and I have given him the option, but he still chooses with his education Eylea over the other drugs. I've offered him, you can move to Vabysmo, you can move to Peganax. I've explained plus, minus, and I give him his choice because he's an educated person, he's a doctor. So, but he still prefers Eylea over the other drugs, and I'm sticking to what he chooses as well. So that's the end of my presentation. Thank you.
Thank you, sir. Thank you for your very insightful presentation and also showing confidence on the Eylea. So now the session is open for question. If anyone has any kind of question, they can ask, or any kind of suggestion. I think I'm audible, na, sir?
Yes, I can hear you.
Okay.
But I can't. Yeah, I can see the screen.
Yeah.
Okay.
So if anyone have any kind of questions, they can ask now, or otherwise we'll move to the next session, to our next speaker. I think there is no question from the audience side. So at the end of the session, if anyone have any kind of question, we'll answer. Thank you.
My slide is visible?
Yes, sir. Your slide is.
Okay.
Thank you, sir.
It's in PowerPoint view right now. Yes.
It is still in PowerPoint view?
Yeah, PowerPoint. We have to.
It's not in slideshow yet. Yes.
Is it okay? Or still PowerPoint?
No, still it is in PowerPoint, sir. Our tech team kindly help out us, sir.
I am going to from current slide, is it?
It is changing, sir, but it is in PowerPoint view.
Sir, can you go to the slideshow menu on the top instead of using that?
Sir,
Go to
sir,
on the
in
top.
bottom orange.
Sir,
But yeah.
please approve.
That also works.
Is it okay now?
No, sir.
Is it okay now? Or is still PowerPoint?
Now it is still in PowerPoint, sir.
But
So you
Sir,
can do
Orange?
one thing, you can just stop the presentation and start again, sir.
So you can click on slideshow in the
Sir,
upper
sir का
Top
hello.
menu,
panel.
top menu, top
Hello.
menu. Right to the
Sir,
animation. Go
Hello.
above. Yes,
Right.
right.
Yeah,
Yeah,
review before the review, sir.
yes.
Slide
Hello.
show.
Then from
And-
current slide, left. Yeah.
Yeah,
Is it okay now?
let's
Or
wait.
still PowerPoint?
Hello. Sir, I am audible.
Yeah, you are audible. Active
सर
you are-
सर का अपग्रेडेड वर्जन नहीं है पावर पॉइंट का, तो उनका सर स्लाइड शो नहीं होगा.
But
Then what
recently,
can we do, sir?
but recently I
Then-
made a presentation with full only. Is it not
Then-
coming? Huh?
मैं
Should I go
भी
with the
try कर रहा
PowerPoint view only? Is it visible now or not?
Is it visible, sir? But it is not in the slides. Like, sir, just click on the presentation.
Just second, sir. I help with you. Just second, sir. Just second, sir. Just second.
Sir,
Okay.
just wait, sir. Our tech team is
Yes.
trying to sort out the issue.
Should I go to the slideshow?
No, sir, just
So
wait.
just second, sir. जो स्लाइड बाजू में ओपन है उसको मैं हाइड कर रहा हूँ और
Okay.
आपका जो स्क्रीन है उसको मैं बड़ा कर रहा हूँ सर, क्योंकि ये स्लाइड शो मोड पे नहीं जाएगा इसीलिए. मेरा एरो है ना वहां पे, अभी क्लिक कीजिए सर एक बार. ये रहा.
आपका एरो का है मुझे दिखाई नहीं दे रहा.
आपको छोटे छोटे स्लाइड दिख रहे हैं सर.
Left side, sir,
Left
first slide.
फर्स्ट स्लाइड पे
Technique-
लेफ्ट साइड पे
This one?
हाँ.
वहां पे ऊपर देखिए सर, एक ग्रेटर देन है.
Sorry.
Greater
ऊपर-
than from current slide.
यस, करंट स्लाइड के वहां पे नहीं सर, वहां पे नहीं.
Then
जहाँ पे छोटे छोटे थंबनेल बने हैं ना स्लाइड के, वहां पे देखिए एक आउटलाइन है स्लाइड्स है, उसके बाजू में देखिए.
हाँ.
Yeah.
Sir, just beside the slide, sir, there is a arrow, less than arrow. Sir, he is saying that. Sir, just ऊपर में जाइए, sir, ऊपर में जाइए. हाँ, sir, just slide, outline, slide, beside that. Sir, नीचे, sir, outline is written, then slide, then move your cursor, then move your cursor, sir, to less than sign. हाँ, उस साइन में है ना सर, उसके राइट साइड में आइए, थोड़ा राइट में आइए. हाँ, लेस देन जो है सर, लेस देन साइन है ना, उसमें क्लिक करने को बोल रहा है. जस्ट
सर बेनिफिट लिखा है उसके बिल्कुल नीचे सर.
किसके
Sir.
नीचे?
सर स्लाइड ना, साइड लिखा है ना, स्लाइड लिखा है, आउटलाइन साइड, उसके राइट साइड में लेस देन एरो है ना सर. हाँ, दिस वन इज सेइंग आउट दिस वन, राइट.
यस. अभी सर यहाँ पे जूम कर दीजिए सर. 72 लिखा है ना,
नीचे सर, बॉटम ऑफ द, हाँ,
थोड़ा और थोड़ा. यस, नाउ
Nice.
परफेक्ट सर.
Now it is coming, but it is
Yes, sir.
small my screen now. Okay. Should I go ahead?
प्लीज कंटिन्यू.
Okay. So thanks, Bears team for this academic meeting. Already my previous speaker has covered some of the important things that I also will share in my presentation. So my topic is evaluating anti-VEGF drugs, molecular characteristics, and their impact on treatment success, mostly focusing on diabetic macular edema. My slides are not moving, maybe, na? Should I go to from current slide view or presentation view?
टेक टीम सर का स्लाइड मूव नहीं हो रहा है, प्लीज हेल्प आउट. हेलो टेक
Can I
टीम.
go to the
हेलो, कैन आई
सर का प्रेजेंटेशन नहीं होगा सर स्लाइड शो मोड पे, क्योंकि उनका सर अपडेटेड वर्जन नहीं है इसीलिए.
हाँ,
So
तो
can-
कैसे नेक्स्ट स्लाइड
can
में
I-
हाउ वी कैन मूव टू द नेक्स्ट स्लाइड?
You can scroll, I think.
क्लिक
Scroll
कीजिए
up and
और
down.
एरो की से
Arrow,
डाउन की यूज
arrow.
कीजिए सर.
now? What is this view? Is it okay? Or still PowerPoint?
सर क्लिक एंड यूज अप एंड डाउन एरो.
I am
एक
using
बार
the
प्रेजेंटेशन पे क्लिक कीजिए सर, प्रेजेंटेशन पे क्लिक कीजिए एंड अप एंड डाउन एरो. यस.
अभी नाउ इट इज चेंजिंग सर, सर जस्ट चेक सर, नेक्स्ट स्लाइड में जाइए सर, प्लीज चेक इट इज मूविंग और नॉट.
Like this only. What is it? If I click on the slide or up and down arrow, it is not moving. Should I start?
So you can start, sir. Then you have to scroll the slide, sir. It is not moving, then just scroll it, then it will come.
It's not moving at all. Now can you see it?
Yes, sir, it is
No.
visible, sir.
It is in PowerPoint mode or full screen?
No, it is in PowerPoint mode, sir. But it is visible, so it is visible.
Okay, if I go to full screen, it will not move.
No, it is okay, sir. It is.
Okay, so I'll not spend time anymore. Okay. So thanks to the Bears team again. So activation of VEGF R1 and VEGF R2 by VEGF and placental growth factor promotes the neovascularization.
I think slides are not moving. So I can share on behalf of sir, if possible.
But why it is happening today?
No, sir, it is now, it's additional disclaimer page. You are on additional disclaimer page.
I think I should start from the beginning.
Sir, first just check, sir, you are comfortable or not, sir. Move to your 3 to 4 slide. First check, then it is better to start from the beginning. Sir, go to the next slide, sir.
Just wait. Something is wrong. Maybe I clicked something wrong.
So just scroll down, sir. Yeah, it is moving, sir. Just scroll down, sir.
It is moving now? Okay, okay.
Moving. It says scroll down, sir. Scroll down, just scroll down.
Is it okay?
It is moving, sir. It is perfect, sir.
Okay.
It is moving, sir.
So the pathogenesis of diabetes and diabetes-related complications are all not new to all of us. So most of the things we already know. So I will skip this pathogenesis mechanism. So all the standard guidelines like DRCR.net, Protocol I, P, and T, all the European and Asian guidelines, they suggest that the anti-VEGF is the first-line treatment for central involving diabetic macular edema. So aflibercept is one of the anti-VEGF that is the topic of discussion today that targets VEGF, the master regulator of disease pathology, and additionally targets the key ligand PIGF, that is placental growth factor. So it has multiple targets like the VEGF-A, VEGF-B, placental growth factor, and galectin. Several, while going to the action of how the drug molecule interacts with the body, there are several molecular factors that determine like the binding affinity, the elimination of half-life, the potency, clinical targets, and molar dosage. These are the major factors that determine actually the efficiency of a drug molecule. So binding affinity that determines how strongly a drug interacts with its targets. So while the actual data of the new molecule faricimab is still not available, while comparing the available data of ranibizumab, brolucizumab, and aflibercept, it is seen that aflibercept has a higher KD value, lower KD value that indicates a higher binding affinity rather. So it is reverse. And while coming to the potency that determines the required concentration of a drug to produce a defined effect. So it is expressed in type of IC50. So again, the lower IC value, 50 value indicates a increased potency, and the available data shows that the aflibercept has the lowest IC value that is it has a higher potency in comparison to the available other anti-VEGF molecules. The data of faricimab is still not available. Then half-life, it provides an insight into the drug concentration in body over a period of time. So the half-life of the available molecules like brolucizumab is 4.3 to 5 days, ranibizumab is 7.2 days, faricimab is 7.5 days, whereas aflibercept is 9.1 to 11 days. That is relatively higher in comparison to other molecules. The binding target determines downstream effects of a drug on disease pathology. So binding target, higher the binding target of a disease pathology, we may consider that it is more effective. So brolucizumab and ranibizumab has single target, that is VEGF-A. Faricimab has two targets, that is VEGF-N and angiopoietin-2, and aflibercept is shown to have four targets like the VEGF-A, placental growth factor, VEGF-B, and galectin-1. Aflibercept significantly decreased intraocular VEGF and placental growth factor levels from the baseline to month 2 in patients with DME. So in patients with DME, there is a VEGF level may grow up to 61 times, whereas plus times. Then, although other anti-VEGFs block VEGF molecules from activating VEGF receptors, presence of elevated placental growth factor may activate VEGF receptor. So that is why placental growth factor is also considered a significant pathogenic pathway for diabetic macular edema. So could targeting additional pathways beyond VEGF-R pathway further improve efficacy and outcome? So angiogenic factors play a critical role in development of edema, retinal vascular permeability, inflammation, neovascularization, and vessel stability. So VEGF-A, VEGF-B, placental growth factor, and angiopoietin pathway, these are all responsible in a different way in the pathogenesis of diabetic macular edema and diabetic macular retinopathy related complications. So is the angiopoietin T or Tie2 pathway a relevant target for the treatment of exudative retinal disease? So while the faricimab molecule has come to market, so there is lots of discussion about the angiopoietin 2 pathway. So it is considered that angiopoietin 2 that faricimab that additional controls helps in its more efficacy in comparison to the other molecules. So in higher, but it is seen that in higher VEGF states, angiopoietin 2 anti-angiogenic activity may promote destabilization of blood vessels, but in low VEGF states that induces by anti-VEGF treatment, angiopoietin 2 may have limited relevance. So Bayer and Regeneron have investigated the angiopoietin 2 pathway in combination with aflibercept in the RUBY and ONYX study. So they have compared the efficacy of this nesfacumab, and a molecule that strongly suppresses the angiopoietin 2 Tie2 receptor pathway, and in comparison to faricimab, it is seen that nesfacumab is more potent in terms of suppression of angiopoietin 2 than in comparison to faricimab. In RUBY and ONYX, they have compared that aflibercept with nesfacumab and aflibercept alone in diabetic macular edema as well as neovascular AMD. RUBY study for diabetic macular edema and ONYX for neovascular AMD. So it is seen that the combination of nesfacumab provided no additional functional benefits over aflibercept monotherapy. So unbalanced study like the USMETE for diabetic macular edema and RHINE for diabetic macular edema and TANAYA for and LUCERNE for neovascular AMD, they have all designs favoring faricimab and the additional angiopoietin 2 pathway targeting with faricimab that did not confer any additional critical benefit over aflibercept. So I am not going to do all those graphs for further discussion. So AVENUE clinical study has shown that ranibizumab and faricimab achieve similar levels of plasma angiopoietin 2 inhibition after one injection. So faricimab failed to meet the primary endpoint of superiority to ranibizumab for BCVA gains at week 36, and levels of angiopoietin 2 inhibition were similar between agents, and suggesting that the angiopoietin 2 mechanism of action of faricimab may provide no additional benefit over anti-VEGF monotherapy. Aflibercept showed the most durable and robust suppression of VEGF and angiopoietin 2 versus brolucizumab and ranibizumab. Aflibercept delivers comprehensive and highly durable targeting where it matters, so already discussed by my previous speaker. So aflibercept has shown a higher binding affinity, higher half-life, higher molecular dose, though brolucizumab has slightly edge over this, and the number of targets also aflibercept has more targets, and potency also it is shown to be having higher potency in different pharmacological studies. So, while coming to the its complications related to aflibercept. It provides unsurpassed vision gains with excellent safety profile across multiple indications, as demonstrated by a wealth of RCT and real-world data. And we have already using aflibercept for more than a decade, and we have seen that very few complications. Rather, we have not seen any significant complications with aflibercept molecule. So aflibercept is a benchmark for efficacy and safety with years of real-world patient experience. So to summarize, aflibercept targets where it matters, VEGF and placental growth factor, thereby inhibiting the downstream signaling via VEGFR1/2, which is the master regulator of pathological angiogenesis. To date, both preclinical and clinical data suggest that there is no additional benefit of targeting alternatives to the VEGFR signaling pathway, and separate independent studies suggest that aflibercept has a greater binding affinity for VEGF, a greater potency, and a longer half-life than other available anti-VEGF agents. These factors contribute to the strong VEGF suppression seen in aflibercept. So to conclude, with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there is maybe limited potential for improvement in functional outcomes for patients. Thank you.
Thank you, sir. Thank you for your wonderful presentation. Thank you. Show your confidence on aflibercept. So now the session open for question and answer. If there is any question, you can ask to the Manojyoti sir. If there is no question from the audience side, then we move to our next speaker. So Dr. Shoma Bhosan.
Good evening, everyone. Sir, can you stop sharing your
Yes.
presentation so that I can share?
I'm having some problem actually.
Our tech team kindly help out the sir to unshare his screen. I'm requesting tech team kindly help to unshare his screen.
So in your top panel, there should be a stop share option in red button. In the Zoom menu, not in the
Multiple screens have opened actually.
You can close the window also, it will prompt you to stop the sharing. Like if you close your PowerPoint, it will prompt you, I think.
I think it is already
Now it's
now it's
Yeah, it has been stopped. So
and sir, your skin is coming, so yeah, it's perfect.
it's not visible, no?
No, right now not visible. Yeah, it's coming, sir. Now it's perfect, sir. Presentation.
So very good evening, everyone. Thank you, previous speakers, for your insightful thoughts about the aflibercept molecule. So most of the theoretical parts about this molecule was nicely covered by both of them. So I will be covering few of my. I will be showing few of my cases about diabetic macular edema. So before showing my cases, just I want to share my thoughts about my treatment pattern about diabetic macular edema, so that there will be an overview about how I prefer to treat diabetic macular edema. So we all know that we have a bouquet of choices about various molecules like ranibizumab biosimilar to ranibizumab, aflibercept, then rolosozumab, and the new kid in the block, that is faricimab. So which drug to choose in which situation? That is a question. Because we all are handling a huge amount of patient in our clinical practice day to day. So we should not use a strong molecule in every clinical situation, like every aspect. Every patient is presenting with diabetic macular edema. So my practice pattern will be, if the patient is presented to me in a better form, like mild diabetic macular edema with a better visual acuity, like 612 or better, there will be no significant drill present. then usually I prefer to start with ranibizumab or ranibizumab biosimilar interchangeably. But if the patient is presented with a severe form of disease, like if the patient's vision is more than worse than 6/18, and if there is significant release present, so in these cases, I prefer to start with aflibercept, because two other drugs which are in newer generation drugs like brolucizumab and faricimab. So brolucizumab has its own limitations like intraocular inflammation, as nice depicted by Dr. Saptarshi Majumdar sir. And faricimab is new kid in the block. It takes more time to the resolution of the diabetic macular edema. So straightway, according to literature also, according to our clinical experience also, aflibercept is the drug of choice in the advanced presentation of the disease. So few of my cases, in naive cases, the aflibercept works best. That is no doubt about this. In this case, this is a moderate NPDR case with a visual acuity 6/18 and CMT is 513 micron. I have given aflibercept first dose. Usually in these cases, I prefer ranibizumab because aflibercept is not required in these cases. But this patient demanded the best molecule, so I have started with aflibercept. So this is the cistern macular edema is gradually resolving after first dose. In this after Q4 regimen, I have given aflibercept second dose, and this is a complete resolution of the diabetic macular edema after that. And the patient is diabetic, well controlled diabetic, and the patient after 4 months also, there is no requirement of the another dose of the aflibercept. So that shows the durability part of the molecule. And the second patient is also about durability. This patient has presented with, as I have said, that severe dreal is present, visual acuity 6/24. I have started with aflibercept first dose. And after the first dose, after 1 month, the cistern macular edema and the neurosensor detachment started resolving. And I have given the second dose of aflibercept. And this is the third dose. This is the picture after the third dose of aflibercept. So this patient is maintaining dry phobia after 7 months of aflibercept injection. So from the journey from this point to 6/24 to 6/9 in this patient after the three loading dose of aflibercept shows that this molecule's durability part and the efficacy part is best among the business. So in this patient, the patient I have started with ranibizumab due to other reasons, not due to clinical manifestation, but probably the patient's Mediclaim has not supporting aflibercept. So I have started with ranibizumab in this case. There is a cistern macular edema with neurosensor detachment. And after third dose of ranibizumab also, there is a persistent CME, though the patient is not well-controlled diabetic, but the ranibizumab is also not responding in this patient after third dose. So I have requested the patient to switch to aflibercept, though the aflibercept was not supported in his medical insurance. So after switching to aflibercept, probably the patient, I'm not very sure, probably the patient has taken patient support program from I have shared the number of the company salesperson. So after the first aflibercept, the cistern macular edema started resolving, and the visual acuity is also improving. And aflibercept second dose, just see after the 3 dose of ranibizumab, there is no such changes, and after 2 doses of aflibercept, the shape and the configuration of the retinal architecture was normalized. So this is the beauty of this molecule, though there is severe drill is present, but this molecule can reorganize the neurosensory retinal architecture very nicely. And this is 12 week after the second dose, and the patient has not followed up after that, but this is the last OCT I have seen. There is a beautiful retinal architecture has restored. In advanced presentation like this, where there is a severe form of cystoid macular cystic changes with hard exudate, large cystic spaces with 60 presentation. So after in this patient, I prefer obviously aflibercept as the first drug of choice. And after aflibercept first dose, this cystoid spaces started resolving, and after the second dose, the cystoid spaces started getting shape. And this is the after the third dose of the patient, and this patient is currently under follow-up. I am just following up this patient, not giving further doses of aflibercept, because after the 3 loading dose, I prefer to wait at least for 3 to 4 months if the vision is stable and if there is no new appearance of cystoid macular edema. And this patient is also, I have given only one aflibercept injection, and after 4 weeks, after 8 weeks, 16 weeks, 24 weeks, also this patient is maintaining a good neurosensory retinal architecture after single dose of aflibercept. Though this patient is well-controlled diabetic, probably that helps in this maintaining the the neurosensory retinal architecture. But this drug's durability also, in my opinion, about 3 to 4 months. In some patients, probably more than that also. So thank you. These are my short presentation. If you have any question, you can ask.
Thank you, sir. Thank you for your sharing your day-to-day life experience and your cases. So I am requesting Anupjyoti sir and Shaptasi if you have any kind of question or any kind of comment on that. Or
Is Eylea 8 mg dose can it be can we get it in India?
yes, sir, we are working on that, sir. Actually, the thing is that the US FDA and European all bodies are approved our 8 mg, but the scenario of India, the DCGI is not giving us the permission to conduct the phase 4 trial. We are still working, sir. We hopeful at the end of this year we are going to launch, sir.
So one of my patients are frequently traveling to Scotland and India in his son's home, and frequently coming to me with the inquiry of Eylea 8 mg, whether it is available or not, because he is getting there.
Import it in a
So you can understand.
Yes, you can import it in. You can state some criteria is there, but it's not directly available here. You have to import it.
Yeah. So you can understand that the US FDA approved, but our DCGI is not going to approve this molecule. So you know the scenario of India, sir. Still, we are trying to manage how we can manage, because Bayer is still strictly compliance-oriented company. Without compliance, we can't do anything. So that's why you are facing these challenges, sir. But still, we are hopeful that at the end of this,
There are a group of chronic patients who are taking. They'll be very happy with the 4 monthly injection. Some of them might go to 4 monthly as well.
so sir, we have the data, sir. We can extend up to 6 months, sir. There's this data in Europe, sir. So it's and most of the patients are, and real world also, sir. The patient they can extend to 6 months.
Okay.
They have a real world.
So my question is to Dr. Saptarshi Majumdar sir, because there are multiple school of thoughts. I am attending many conferences. There are AIMS school of thoughts, and there is PGI school of thoughts. Usually, AIMS people are very much into PRN regimen. What is any logic behind this? Is it followed?
When what I realized when I started out, I was also PRN mode only for the first 3 years or 4 years. But then I was seeing that my patients were not doing that well sometimes. So now I'm a bit more aggressive. Like I give like say like 2 tries. Like if it worsens twice, like then I do them a fixed dose. Like say if I'm using ranibizumab, I have given 2 or 3 doses, and then I was doing PRN, but the vision dropped over 3 months. Then I tell him you are on now in fixed dosing, not even treat and extend. I tell you go fixed dosing 2 months, 2 months, 2 doses. Then I'll decide what kind of group I'll put you in. Now I am writing in my prescription notes what is my plan, because when you're seeing so many patients, you forget what you are doing actually. So I
Right.
write T plus E 2 months or weeks, whatever. And some patients, like most of them get confused when you are saying like I'll extend the duration, I'll extend the duration. So the bad patients, now I write fixed dosing at 2 months for 2 doses, fixed dosing 2 months for 3 doses that I mentioned. So I also remember, and the patient also knows. But this is based on the patients who are compliant. But like out of your 100 patients, probably 30 patients are like this who will follow your plan. So I do that for those patients. The other patients are all on PRN only. Especially in CNVM, what I have realized ki I used to undertreat too much, like first 3 years of my practice. After that, I have probably improved a bit. So, but TNE is the way to go, I feel. But in that case, also you have to keep maintaining your records properly. Second, your patient should also be aware. Some of them are very clever. They only tell, "हाँ, 2.5 महीना तो हो गया सर, अभी तो injection कर दो." So those patients are good patients. Like you don't have to tell them कि भाई करना है. And some patients also figure out what is their treatment duration on their head. कि now to I'm going to go bad. They know. Like the patients who has crossed 1 year, they have their judgment. मतलब before the OCT goes bad, they know कि भाई मेरा number आने वाला है. So those guys generally come early. But the non-compliant patients, they turn up suddenly. Like 2 months you have treated, they are not there with you. At month 4 or month 6, they have come with like 3 lines drop of vision. So it's very difficult to get them back, especially the diabetic patients. The CNVM is like a graph which like they are under your treatment. They generally don't get lost, but the diabetic patients always get lost somehow.
And they usually go for doctor shopping also. Another.
Yes, and many times it's also the illness, I feel. Many times, like something is happening with them, many things are happening, like sometimes the kidney, sometimes heart. Like I get very old patients, like because in Durgapur, when I'm practicing, there are other medical retina guys. So I generally get I shouldn't say the word leftovers, like 3 injection ho gaya, 4 injection ho gaya, Dr. SPM opinion. So I'm treating those chronic cases only. So my group of patients are a bit, they have already been through everything. But the treatment naive patients, I see them behave nicely with, so it depends on the patients you are treating. You get a certain cohort of patients. So you have to modify your practice pattern according to your cohort of patients. Like
Right.
my practice pattern in Sharafuli is different, Durgapur is different. Sharafuli, I get treatment naive patients. I know what to do. In Durgapur, even I am confused most of the time. Like I have to judge the person. What does he want? Like, will he pay that much for 1 line improvement of vision? Well, that also I have to figure out in my head. So it's difficult to treat those patients. But you put your best foot forward, explain them what can be done, and then go ahead with the best drug in hand.
Mahavjyoti sir, what is your way of practicing in naive patient and in refractory patient who are coming after multiple injections in other doctors?
I could not get the question.
What is the what is the way of practicing in diabetic macular edema in a fresh naive patient, and if the patient has taken multiple injection in other hospitals and came to you for opinion?
See, for fresh and naive patients, it is not a difficult case. So you can, depending upon the pattern of edema, control of the blood sugar level, all these things, if you assess, so treatment is not really difficult. But for only it is difficult for those refractory cases. Just today also I got one patient around 15, 16 case injection already he has taken, but he has tried all sorts of anti-VEGF, but he still his edema just recurs. After one injection, that's sufficient. So last time actually he tried aflibercept also, then he tried ranibizumab, then biosimilars, Azodex also. Last time I tried Paginox, brolucizumab, but that also did not really work. And also he has undergone Pocalagel. So after all these things also it is recurring. But the biggest problem with the patient is that his blood sugar is really fluctuating. Sometimes it comes very low, say around 70, 80, and sometimes it goes up to 300. So I think that factor is one important factor for patients, because whatever anti-VEGF you try, if there is no other problem like a macular traction or thing, at least if the blood sugar is properly controlled, it should work. But if it does not really work, then there must be some underlying factor that is to be evaluated, from like nephropathy or additional hypertension changes, or a very much fluctuating blood sugar. What is your opinion? Anything?
Also anemia, sir, in
Yeah,
female,
definitely. Anemia is one major factor
which
for
is
us
missed by
patients.
many. Like many times, the patient is under endocrinology follow-up also, but the hemoglobin is missed. So that we can
Yes.
just check in the OPD as well. It just
Yes.
that helps a bit. But
Very
some
good.
of the
Yeah.
patients don't respond to many things. That is true. Like definitely, like few patients, like not talking about DME, like in CRVO cases which are very chronic, like partially compensated CRVOs, not the very bad ones which go into NVG. But these patients,
Yes.
what I am doing is cycling. Basically, I give a Ozurdex at say 6 months, and then either anti-VEGF like Accentrix, Eylea, and I keep alternating between them. So with around 2 injection, I'm able to maintain about 9 months of treatment in these patients, because I need to give a anti-VEGF as well. This is specifically to CRVO cases. This kind of a strategy might be tried in bad severe NPD or DME patients as well. I feel like alternating between steroids and strong VEGF-A trap like Eylea or any drug, like for example. But Eylea also has some longevity about it. So instead of Accentrix, Eylea and Ozurdex, if we can alternate, that could also help some patients, I feel.
What is your comment about the loading dose in diabetic macular edema? Do you prefer loading dose or just PRN?
Definitely, but problem is most of the patients are bilateral and most of them can't afford three injections. So somehow, most of my patients, what I do is right now counsel for a first line like ranibizumab only, because if you write uh, and in our hospital we have biosimilars and some shared biosimilars also which cost less. So I don't push them there, but I give them an option, like if you are paying from your pocket, then you can think about that. But when I'm switching, say a patient is not responding, then I switch them to a higher drug, like say Eylea probably. So for diabetics, my first line is usually still ranibizumab because of the cost factor. I'm treating two eyes at the same time, so that's the whole point. It's into two. When you're treating CNU, it's into one. Basically, you're treating one eye at that point.
So do you prefer biosimilar or parent molecule ranibizumab in the
For
first?
me,
Because
yeah, but for me, I feel I am quite happy with Trazimab in most of my patients. Like if I tell a brand, it shouldn't be wrong, but Accentrix, like the patients get divided. Like person who has got Mediclaim will go for Accentrix only. So 60% of the patients are in Accentrix. The 40% group is in biosimilar group. And I don't write brand name. I write ranibizumab biosimilar, and the patient has a right to choose after that. So it depends on the counter. They generally end up with Razumab, but the newer drugs are also coming up, Osiva, Raniais. So even those numbers are picking up. But for choosing biosimilar, I give them the option. Like I don't choose a particular brand for them. But when I switch over, the next step is Eylea, basically. Next step is Eylea. Like you can't go for Vabysmo or for say Peganex. I don't like Peganex too much in DMEs at least, because I don't know, my personal experience could be bad. Like in 4 or 5 patients, the drying was too slow for me, as in the patient, well, I cannot show the vision improved. The surprising part in those Peganex group patients where the vision had improved a bit, but the scan was like 30% probably down. While with Eylea, the drying is much faster, I feel, in the OCT scan as well. So when you have to show a patient a report, but that might be just 4 patients, so I can't just comment like that. But I feel my next step after ranibizumab is Eylea, usually second step. And in a chronic case, when the patient is with me for 8 months or 9 months, then I give an option of Ozurdex at that point. So that is my practice pattern usually. But sometimes the patient knows, like a high paying patient who's educated, who has read a lot, he also gives me an option sometimes. You can do this also. Like, are you giving this drug? Then I give that drug as well. So, but second line is always Eylea for me, at least.
How frequently you try this steroid, Ozurdex?
Ozurdex, sir, actually most of my patients, Ozurdex are my vitrectomy patients. Like PDR cases, like say if I'm operating, say 50 cases, out of those, 25 will have some edema, which will be at month 3 or something. So those I shift to Ozurdex. And some of them who have their sugars in control, their central perfusion is somehow okay. That is a surprising part I see. The PDR cases who take care of themselves after being diagnosed with PDR, their macular perfusion somehow stays normal. Matlab, eye laser, I do my surgery. Those patients don't require injections much afterwards. And those patients who went to PDR and are not serious about their PDR, they're also having nephropathy, anemia, various things, comorbidities. Those patients will end up with vitrectomy and also Ozurdex probably later on. So post-vit are my steroid cases mostly. And obviously the other end of the spectrum is people who can't pay and need to be treated. IVTA, I go for that. So I generally base my prescription in I write one thing above, which is like what he can afford probably. And second, I do give options because surprisingly, sometimes one of my patients had to, why didn't you offer this to me earlier? Like 1 or 2 patients have told me. It could have, like when they see the longevity of a drug, sometimes they, why are you giving me ranibizumab for so long? You could have switched me before. So 1 or 2 patients have spoken. After that, I changed my practice pattern. I have given options below also. So that depends on the patient to patient. But I write my prescription in 2 ways. One column is what he is going to probably take. And second, if you want kind of a drug, like if you can't, these are the higher drugs.
Thank you. Thank you, Dr. Saptarshi and Somav.
Thank you, sir.
So if there is no any other comment, can we leave?
So, thank you, Manavjyoti sir. Thank you, Saptarshi sir. Thank you, Somav sir. Thank you for your valuable time. Thank you for a very insightful discussion. It will also help our audience for helpful for their day-to-day practice. So hopefully in future we'll again conducting this kind of meeting. And again, thanks again for your valuable time. Thanks from Bayas Science.
Thank you and good night.
Thanks.
Good, bye.
Good.
Thanks and good night to all.
So now I'm requesting our tech team kindly log up this.
Okay, sir.